So Steph, if there was one thing you would change to improve patient safety, what would it be?
I think one of the things, Leah, is the awareness of the potency differences between hydromorphone and morphine.
And when it comes to actually being in practice, how does that have an effect on patient safety?
One of the issues with hydromorphone is it's 7 to 10 times more potent than morphine. When a physician or a practitioner is ordering hydromorphone, they may order 2 to 4 milligrams of hydromorphone. They're used to ordering 2 to 4 milligrams of morphine. And what happens with that is the hydromorphone is just so much more potent than the morphine that patients can get into trouble with oversedation and respiratory depression.
And this is something that ECRI Institute PSO has seen a lot of.
Yes, we've seen multiple issues, reports with opioid events, and one of the main opioid events that we see often is the hydromorphone use.
We often refer to education as a low-level strategy for patient safety improvement because it doesn't really enforce the best practice. So what is a stronger strategy to really help practitioners ensure that the proper dosage of opioid is being prescribed?
Well, one of the ways that we've recommended and that we have seen other facilities put into practice is the use of order sets. Many facilities are on electronic medical records, so you can have an order set built into the electronic medical record for a patient who is opioid naive or opioid tolerant, and that's 2 different order sets. And even if your facility doesn't have CPOE, a lot of facilities, they may have written pre-printed order sets for the practitioners to use also.
How do you tell the difference between a patient who is opioid tolerant and opioid naive?
Somebody who is opioid tolerant is a person who has been taking a certain amount of an opioid, it doesn't matter which opioid, any of the opioids, for a certain period of time. The confusion occurs when you might have a patient who has hip or knee pain and they're on oxycodone as an outpatient. And they may say, do you take opioids or pain medications? And they may say, oh yeah, when I have pain I might take one of my oxycodones once a day. And I've been doing that for about a month now. But taking one opioid once a day does not make somebody opioid tolerant.
And then that will affect then how that patient is treated if they're ever an inpatient or if they need to be prescribed a new or stronger opioid.
Correct. Somebody who is opioid tolerant, they can, depending on what they were taking before and how much they were taking, they may tolerate a higher dose of opioid medication. But you have to remember 2 milligrams of hydromorphone, that's going to be 14 to 20 milligrams equivalent to morphine. So that's a pretty high dose. It would be highly unusual to see an opioid naive patient receiving 14 to 20 milligrams of hydromorphone.
Is there one patient population in particular that's especially affected by the prescribing concerns with opioids?
One of our most commonly affected patient populations is the elderly, especially the 75-year-old and above. They may be more sensitive to the opioids. Also, they are going to be, have other comorbid conditions that can also lead to increased risk of sedation and respiratory problems.
And they're likely on several additional medications as well.
Yes, one of the common things, or one thing that you need to really look out for, is drug interactions. They may be on medications for sleep or anxiety, and the interaction between the opioids and those medications can definitely increase the risk of sedation and respiratory depression.